Good evening, everyone. Today I am presenting a case of 1 year 9-month-old male child of birth order 2, born out of non-consanguineous marriage, brought by his mother, whose reliability is fat, with history of cough for 1 week, history of fast, history of presenting illness, history of cough for 1 week, which was insidious in onset and progressive in nature, with no postural or diurnal variation. History of difficulty in breathing for past 1 week, which was also insidious in onset and progressed in severity. Initially, the child had breathlessness while feeding, which has gradually progressed to breathlessness even at rest, which is class 4 breathlessness, associated with chest in drawing and poor oral intake. History of inadequate weight gain.
Yeah, Sharon, can you go back to the first and second slide, please?
Yes, sir.
This is the first slide. You have a almost 2-year-old boy, right?
Yes, sir.
And
Yes,
he
sir.
has basically respiratory symptoms, right? Cough and fast breathing.
Yes, sir.
And the cough is 1 week. Next slide is next slide
Breathlessness for
would be
1 week.
breathlessness again, practically same, almost simultaneously.
Yes, sir.
Insidious onset and progress in severity, and went into class 4 according to you. Now the point is,
Yes,
we are having a discussion on basically a respiratory difficulty in a 2-year-old child.
yes, sir.
And this class 4 classification at this point
Yes,
may be a little premature, because class 4 symptomatology assessment is for cardiovascular system. The people who are hearing this are not very sure whether you are dealing with a cardiac situation.
Okay,
So right
sir.
now we can only have a respiratory difficulty. With fever, without fever, anyway you will tell. So at this particular point, it is safer not to mention the thing. You can only say that initially child had breathlessness while feeding, which has now progressed to breathlessness even at rest. For example, pneumonia, bronchiolitis, everybody will have this breathlessness at rest. When you start saying class 4, it implies that you are dealing with what you call as Rose classification of heart failure, right?
Okay,
Purely heart failure. So and that question brings another question or another question. Dr. Surya?
Yes, sir.
Yeah. You are aware of this Rose classification, right?
Yes, sir. It has 4 classes, sir.
Rose, there are 4 classes. Up to what age is Rose classification applicable?
Less than 2 years, sir.
Less than. So what about modified Rose? See, actually, up to 10 years, actually, you know. So even though we primarily use Rose classification below 2 years and apply NYHA for older children, this Rose classification is actually applicable up to 10 years. This is called modified Rose classification. Only thing is the statements are different, because from 2 years to 10 years, the kind of sentences are more or similar to NYHA, whereas below 2 years is the actual, based on respiratory difficulty, success cycle, etc. So you should be aware that this Rose is applicable up to 10 years.
10 years.
Then you're saying chest indrawing and poor oral intake. Okay, go ahead. Sharon?
Yes, sir. History of inadequate weight gain present, history of increased precordial activity present, history of suppressed suck cycle present, history of forehead sweating present, history of recurrent respiratory tract infection present, no history of pedal edema, no history of reduced urine output, no history of abdominal distension, no history of vomiting, no history.
Okay, no history, right. Go ahead.
No history of fever or petechiae or painful fingertips. No history of bluish discoloration of lips and mucous membrane. No history of convulsion.
Okay, we'll stop at this point and go back to your first slide. I mean, first means then, the third slide, I suppose. Yeah. See, the point again, I told you, 2-year-old, fever, cough and breathlessness. So naturally, any baby coming to a pediatrician or a pediatric cardiologist even is basically we suspect a respiratory infection, right? So naturally, the first question after the first presentation would be that of fever. So you have relegated the fever to the second slide, the fourth slide.
Your voice is breaking. Why can't you keep the mic a little nearer?
Okay. See, you have not touched upon the fever in the beginning. You have given that fever aspect very low priority, but that is probably not correct, because this slide again tells you the person who is presenting is very much oriented towards the cardiovascular system problem. But you should always be aware that whenever a 2-year-old child has cough and breathlessness, you should think of a respiratory infection with or without heart failure, or heart failure with or without respiratory infection. So fever should come first. And secondly, you have given the fever along with the petechia and all, implying that basically your logic is that you are looked for or you are asked for a history of suggestive of an infective endocarditis. Am I correct, Sharon?
Yes, sir. Yes,
you are thinking about an infective endocarditis in a 19-month-old baby. How common is it to have infective endocarditis in a child below 2 years? Uncommon, common?
Sir, the risk of infective endocarditis increases.
No. My question is very simple. Is it common or uncommon to have infective endocarditis below the age of 2 years?
Sir, it is uncommon before the eruption of second teeth, sir. So it is uncommon, sir.
What is that? What is that? What is that? I did not get it.
The most common risk factor for infective endocarditis is dental caries and.
Okay. So, I see. So you
loss,
feel that because the most common precipitating event is a dental procedure, and if the child does not have a tooth or a teeth, the chance is less likely. That is a very interesting observation, which I don't think I will agree. It is very, that is not the reason, right? Because one point, that is usually in infective endocarditis in children, 75 to 80%, we don't know actually the portal of entry. Probably the most common portal of entry in a child would be dental problem, but that is less than 10%. But generally, the reason usually we feel is because the organisms which have got a capability of attaching itself to the endocardium are not the organisms which affect children below the age of 2 years. So generally, unless it is a very immunocompromised child, you don't usually get infective endocarditis in below 2 years. For example, during my practice, for my career, I think I have seen only 2 children below 2 years having infective endocarditis. One was a Down syndrome child, another was a newborn baby. That is a different area. Below 2 years, the most common period where you get an infective endocarditis is newborn, because we have a called high-end newborn centers where low birth weight babies are. The tooth business, I am afraid that I think it may not be very welcome to your examiners. Okay, right. So the reason is different. Okay, can you go back to just the previous slide? Yeah, here you are talking about the inadequate weight gain, which is failure to thrive. Then you have the increased precordial activity suggesting a cardiovascular problem, suck rest cycle, history of forehead setting. Everything is in favor of this sort of heart failure, and recurrent respiratory infection. In terms of cardiology, naturally we think of a increased pulmonary blood flow, and then you put up pedal edema, urine output, abdominal distension, vomiting. Next slide. Yeah, history of fever and painful fingertips. So see, this is a point. If you combine fever with petechia and painful fingertips, and the examiner may not be very comfortable with that statement, and then he or she can make you a little uncomfortable. And of course, you can say no history of bruises, discoloration of lips and makeup. Okay, right, go ahead. So what, for the last 2 slides, what are you conveying to us? What is your message that to us?
Sir, the child has a 1-week history of cough and difficulty in breathing, sir. Both of these were insidious in onset, are not associated with fever, sir. So most probably it could be a congenital heart disease, which is causing these symptoms, sir.
No. If you have a 21-month-old baby who is having 1-week history of difficulty in breathing and cough, you will think generally of heart failure, right? Am I right?
Yes,
that
sir.
Apart from the respiratory infection. So if you think of heart failure coming to this 21-month-old baby, naturally, I agree, you should think of a congenital heart disease. Okay, that is one possibility. Okay, and any other disease at this, this is again, previous history is there, I agree. But if you have a first time the baby comes with breathlessness of 1 week duration in a 2-year-old child, other than CHD, congenital heart disease, what will you think of, Dr. Bhuvaneshwari?
Cardiomyopathy, sir. Dilated cardiomyopathy.
Cardiomyopathy. One, okay, I partially agree. 1 week history. 1 week history. So naturally, you should think of a cardiomyopathy.
Myocarditis.
Yes, you will think of a exactly. So you will think of a I will think of a myocarditis first, and then I will think of a post myocarditis or myocarditis dissolving into a cardiomyopathy. Agree. So you should think that is another very important point. Any postgraduate discussing a recent onset suggestive heart failure should not only expect a congenital heart disease, you should expect an acquired heart disease. I suppose the most likely possibility would be a myocarditis, because ultimately in a child with acquired causes or other causes are rheumatic fever, carditis, which is very unlikely, and infected endocarditis, we just know that again very uncommon. So myocarditis. Any other reason other than congenital heart disease for a recent onset heart failure in a 2-year-old? Sharon? This is cough and all, so I agree this is a respiratory also is there. But any other reason for a recent onset heart failure in a 2-year-old child? May not be relevant in this child, but still you should think. Baby comes with the heart failure in our casualty. Any other possibility? Surya Prakash? See, a very recent onset, like 2 or 3 days, suppose it is 2 or 3 days duration with breathlessness, as we said in class 4 now. You should think of an arrhythmia also, right? You should think of a supraventricular tachycardia, which will persist, and that can produce a dilated cardiomyopathy-like picture. That is. Okay. Another thing is, suppose this is a congenital heart disease, Sharon, and with the big history you have given, what are the possibilities? What are the groups of diseases which are like among the heart diseases?
Sir, at this age, congenital heart disease presenting with failure include large VSD, PDA,
Okay.
anomalous.
No. If you think about it, because you should think in a physiological manner. So, what are they? These VSD and PDA. Let's leave Alka later. It is a left to
right shunt, sir.
Left to right shunt. Okay. Do you know how you classify this left to right shunt, Surya Prakash? Physiologically.
Left to side is the high output state, high volume output state, and obstructive lesion.
No, what I'm asking you is that you have a left to right shunt at various levels. No, you can have
a
exactly. So you can have a pre-tricuspid left to right and a post-tricuspid left to right. In this child, would you expect which one, pre-tricuspid or post-tricuspid?
Post-tricuspid, sir.
You should think of a post-tricuspid left to right. Okay, that is one. Any other congenital heart disease which is capable of producing?
Are you busy now?
Sharon, any other cause, other congenital heart disease? Other than left to right shunt.
Sir, critical aortic stenosis, coarctation of aorta can present with failure.
So you're talking about a severe obstruction.
The quick only.
Obstruction.
Rajendran, you have to mute. Sir called me, but Rajendran.
So you should think of a severe obstruction of the left side, right? That is aortic stenosis, and you said coarctation. Now, Sharon, if you
that one I didn't receive invitation.
Any other possibility, Sharon?
Okay.
We'll come back to this again, but again, I just want to have a list.
Shall I talk to you now? Yeah, actually, that from Hema, Bindu, and Narmada sent a mail to me, and they want to start a women's wing in Tamil Nadu. They want to start. And they want our permission.
Even TJ can present, sir, but the child wouldn't have survived this far without going.
No, what we are saying is about a 2-year-old child. What are the 2 or 1.5-year-old child? TJ, of course, very unlikely. Any other group of disorder, congenital heart disease, which can cause heart failure? other than left right shunt and stenotic lesion. You are right, absolutely right. Then you said something about an unusual condition, no? You were starting.
I am
Interrupted you.
I think
Anomalous left coronary.
What is that?
Anomalous left coronary artery from pulmonary artery, sir.
So that is a rare condition, but it can present with the heart failure. When does it present usually, Sharon?
Sir,
I think surprise.
6 weeks to 4 months, sir.
How old is this baby?
21 months old, sir.
Very unlikely to have, no?
Yes,
If
sir.
it was an alcapa, most of them would have died before intervening. It's very unusual to have an alcapa, but we have seen, yes.
Actually, as a state office bearers, we have to come and inaugurate that new branch in Zoom. They are calling me. I told I have to decide in the evening only. I can decide it well. And I think they claim that they approved central EB for starting all the new branches before April. They are telling.
Okay, Sharon.
I think this.
Sir?
I think it's.
Yeah, Sharon. Alcapa is another cause of heart failure in infancy, and left to right shunt, post tricuspid, and obstructions. But again, you should remember that left to right shunts, post tricuspid left to right shunt.
I think we have to go for men's swing. I think we can start for men's swing. I think.
Rajendran, you are this thing.
Everybody will start some branch. No?
Large AV fistula can cause failure.
Okay. No, I think we will wait for, yeah. Dr. Rajendran, I think he probably have not muted. That is why.
Yeah, that's, I think they are making, obviously it knows that election campaigning, for the.
Yes, somebody has to tell him. Yes, somebody has to tell him.
Rajendran sir,
Yeah.
kindly mute, sir.
Dr. Rajendran, can you mute, please?
Yeah. And I think it's, Narmada is the main person, he's I think claiming.
See, DAP, this thing forced to mute Dr. Rajendran.
I think in
No,
Tamil Nadu,
you
I
can-
think no problem.
You can send a message also, no?
Bring
You
that
can send
woman
a-
sentiment, I think, that's, I know, it's not good for that association also. No, it's wholeheartedly I feel this is not good for, now suddenly they are.
Tirumurugan, please tell Rajendran.
Take care of girl child, they are going to take care of adolescent girl child. Now we have neglected girl child and other things, adolescent girls we are neglecting. I think how they are claiming this way, they are claiming now.
Maybe Dr. Bala, you can probably phone him or.
It's not good.
So he's already in his,
Yeah.
he's already in
I
his
think you
phone,
could
sir.
discuss and I think.
Why? Oh, yeah, correct. I forgot.
Stop, no, that, instead of things, they have to need
But the host can mute Dr. Rajendran.
IAP, no, that EB, no. Any subchapter coming to state, no?
Okay. Sharon?
Sir?
Yeah. So basically, you were thinking of a congenital heart disease, post tricuspid left to right shunt. Then we talked about the less likely possibility of a.
Who has started this woman doing, no? That's why that they're splitting men and women like that.
Stenotic lesions. And then you thought about a rare condition, which is very unusual to present for the first time or the survived up to 2 years. These are the possibilities you mentioned. Along with that, we should also think, maybe not in this baby, in a younger infant, like below 1 year, we should also think of a admixture lesions. Admixture lesions like a single ventricle or a trungus or whatever, which would present with severe heart failure with a very mild cyanosis, so that you will miss the cyanosis. That also has to be thought of, but you should remember that all these admixture lesions, except for single atrium, won't survive up to 2 years without a surgical intervention.
Yes, sir.
I think Dr. Balasubramanian, this is the right time to convey to Dr. Rajendran the muting business.
Ah, yes, sir, he is muted.
Sir, he is muted, sir.
Okay, very
Now
good.
only he is muted.
Yeah, okay. Yeah. So these are the possibilities, right? And there is no history of bluish discoloration of lips and mucous membranes, so that historically, at least, you are dealing with an acyanotic congenital heart disease. But whenever you think of an acyanotic congenital heart disease, you must always remember that you can have admixture lesions. They will present almost like a post-tricuspid shunt. For example, a single ventricle or a DORV with PAH, they will behave like a VSD. A newborn with a truncus may behave like a PDA with a high volume pulse and heart failure. So that also has to be thought of when you deal with the infant with heart failure. Another practical thing you should remember always in practice, or not only in the examination, is that generally, if you have a left to right shunt, which would present with heart failure, they would present with heart failure within 1 year. It's very unlikely that a significant left to right shunt will have no heart failure by 1 year and then develop suddenly, unless there are some precipitating factors. So, Bhuvaneshwari, what are the left to right shunts, like a VSD or a large PDA or AV canal defect? They can develop heart failure after 1 year for the first time. Here, Sharon's patient has already had problems from the beginning itself. But suppose you have a 2-year-old child with a large VSD or AVSD or whatever, presents for the first time with heart failure after or around 2 years. What are the possibilities? Bhuvaneshwari.
Small VSD.
Hello?
Hello, sir.
Yeah, I can hear you.
Small VSD.
Okay. Now, if it is a small VSD, if it is a small VSD, how can it develop heart failure by 2 years? We are talking about a significant VSD does not develop heart failure within the first year also. Exactly. Very good. There's a possibility of an infective endocarditis, like complication. What are the other complications which can happen to a VSD or an AVSD? Like, see, for example, many of the VSDs are just below the aortic valve. So suppose there is a prolapse of this aortic valve. What will happen to the aortic valve? There will be
Aortic regurgitation.
Aortic regurgitation is possible. That can also occur due to an infective endocarditis. So aortic regurgitation is an important entity where you have a stable VSD developing a heart failure. That is one. Now, suppose AV septal defect does not present for the first, if it does not present with heart failure in the first year, then develops heart failure. What is the likely reason, Surya Prakash? Generally, AVSD will present with heart failure in the first year of life. Suppose they are relatively stable, maybe because of the severe pulmonary arterial hypertension, they may not sometimes present in the first year. But then they develop heart failure. What is the likely possibility? So that actually, for that answer, Surya Prakash should know what are the components of atrioventricular septal defect. Now, apart from an inlet VSD and a primum ASD, what else is there in an AVS septal defect?
Endocardial cushion.
No, it's called endocardial cushion defect.
Sir, it could be a jet board defect causing shunt from the left ventricle to the right atrium, sir.
Now, suppose something happens, there is a jet from LV to LA in an AVSD. What is it called? In a normal situation, if you have a leak from the jet from the LV to LA during systole, what is it called?
Mitral regurgitation.
Mitral regurgitation. So you must remember all AVSDs without exception have left AV valve regurgitation, even in a single AV valve. See, that can progress over time and they can become significantly regurgitant, and that can destabilize the baby. So VSD or whatever with infective endocarditis, AVSD with mitral regurgitation, then VSD with the development of AR, VSD with development of SVT. All these are factors which will precipitate heart failure in an otherwise stable post-tricuspid left to right shunt. And of course, you think of a medical condition like a severe anemia, pneumonia, etc. also is possible. So that is also there, right? So now we'll go ahead. So basically, you are conveying to us that you are dealing. You can go back to the previous slide. Next slide. No, not next, previous. Next one. Yeah. So here, no, previous one. Yeah. So based on this factor, like inadequate weight gain, hyperactivity, heart failure feature, recurrent respiratory infection, we are essentially turning towards the post-tricuspid shunt, right?
Yes, sir.
Yeah. Which are the post-tricuspid shunts that you know of other than VSD and PDA?
Sir, aortopulmonary window, sir.
Aortopulmonary window and atrioventricular septal,
Septal.
right? Okay, go ahead.
Past
Dr.
is-
Now, Dr. Bhuma and Dr. Balasubramaniam, can you, can you?
Yes, sir. As you correctly pointed out, the first itself, they should not be like, this is okay in a clinical forum where we, like Dr. Zulfikar is called up, it's only cardiology case. So in exam, it will not be like that. So unbiased they should be. So it could be respiratory or even metabolic causes of an acute onset of breathlessness like diabetic ketoacidosis. We do see cases in the younger age group. Post-COVID, it is more common now. So they have to think about like that also. And related to bronchial asthma, they will be, sometimes they deny. They think like it is a stigma to say my child is suffering from a bronchial asthma. So sudden onset of breathlessness with cough, you should think about that. And that too when there is no fever. And in the present illness itself, you are telling your duration, you always stick on to the timeline. So your present illness history is only 1 week. So in that, how will you call it as a recurrent respiratory tract infection? So you should have some period to say it is a recurrent respiratory tract infection. So if this, in such cases, it will be better if you present it, since the child is having symptoms from 5 months of age, it will be better, but either way it can be accepted. So this is the routine things we will not say it is a fault, but if we do it in the correct way, it will give a very good impression that or you are in line with the case.
Yes, ma'am. Okay, ma'am.
Karen, you understood. For example, all these things which you said previously, the third and fourth slide, probably could come here in the past history rather than at that time. You understand? That's a very important point. That's a very important point had to be highlighted. Okay, go ahead.
Past history of similar illness in the past at 5 months and 1 year, 4 months of age. First episode at 5 months of age, the child had cough, fast breathing, associated with suppressed suck cycle and increased sweating aggravated while feeding the baby. For the above complaints, the child was taken to private hospital where he was evaluated and found to have some heart disease and was treated with oxygen, IV and oral medication. Discharged with oral medication. The child's symptoms improved with oral medication. He developed similar at 1 year, 4 months of age, requiring hospitalization for 10 days.
We'll stop at this. No, previous slide, I will go. Yeah. So this is again, now you are basically saying that there is some sort of a recurrent respiratory infection and they had a bad infection because they needed IV therapy in ICU and all. And the baby was discharged with the oral medication. Your possibilities were basically congenital heart disease, left to right shunt, obstructive lesions, and all the other things. And the baby is on oral medication on discharge. So, which are likely medications? So you said plural, oral medications. What are the likely medications?
It could be a diuretic, sir.
Okay, it will be a diuretic. Most likely, it will be
furosemide, sir.
Furosemide, right? But suppose the baby is getting a second drug, which would be likely?
Sir, digoxin, sir.
You can be on digoxin. Okay, suppose they said, no, my baby is not getting digoxin, some other funny name. So what is likely?
Sir, AC inhibitors like enalapril.
AC inhibitor may be likely. And you should also know that generally, basically, we are all pediatric people. We are still fond of digoxin, but nowadays, the second line drug is generally in a left to right shunt is an ACE inhibitor because all these post-tricuspid shunts will have no LV dysfunction. So digoxin may not be a very useful drug in a a post-tricuspid left tricuspid. So usually we start with second line would be generally ACE inhibitor. Two-thirds, at least two-thirds of pediatric cardiologists and be using the second line as ACE inhibitor, right? So then usual ACE inhibitor, as you were told me, is enalapril, right?
Yes, sir.
Okay. Now suppose you have, what are the other ACE inhibitors that you know of, Surya Prakash? Surya Prakash, what are the other ACE inhibitors that you are aware of?
Captopril, lisinopril.
Surya Prakash is?
Surya Prakash.
Surya Prakash happens to be a male of the species, right?
Captopril,
Lisinopril. Oh,
Captopril.
Okay, correct.
Hello,
Correct.
sir. Captopril.
Yeah, I can.
Captopril,
Yes,
Amipril, lisinopril.
Okay. Of which is relatively used to be more commonly used in pediatric practice? Captopril was used. No, captopril right now is not available. That is why we are switching on to enalapril, right? So all this, what is the difference between this? What is the basis of these different kind of ACE inhibitors? Surya Prakash. They have a different kind of side chain. Some will have sulfhydryl, some will have hydroxy, all those things. That is why they are different. Basically, the same family. Anyway, so the baby might have been on diuretic and digoxin. Suppose they say, mother says, there is a third drug, third medicine. Our medicine also baby is given. What would be the likely possibility with our practice? Two cardiac drugs and maybe child may be on a yeah, they may be on an iron also, right? So it may be on an iron. Then sometimes we even give spironolactone to add to this this thing. And Bhuvaneshwari, suppose you add spironolactone to a combination of diuretic, furosemide, and enalapril. What can be a problem? Potential problem?
Hyperkalemia can occur.
Very good. Hyperkalemia can occur. So whenever you combine an ACE inhibitor with a spironolactone, you should be very, very careful. But generally, it is taken care of by the diuretic like a furosemide. Okay. So these are the likely drugs. So that is for a post-tricuspid left tricuspid. Suppose this baby had a stenotic lesion and waiting for a surgery. What could be an oral medication for that? Can you give me an example of a stenotic lesion where you are giving some drugs and waiting, the child is waiting for a surgery? Sharon?
Sir, prostaglandin, sir.
2-year-old child, prostaglandin. We're talking about an infant or a post-infant who has a stenotic lesion and is waiting for a surgery and the child is on some oral medication. Logically, you mentioned that particular disease earlier when we talked about a stenotic lesion on the. What are the stenotic lesions on the left side? There are only 2 stenotic lesions. Which are they? Sharon?
Aortic stenosis, sir.
And
Coarctation of aorta.
So what is the consequence of coarctation in infancy and childhood? What is the pathophysiological abnormality which is associated with the coarctation? Hypertension. So you can have an upper limb hypertension. So what you call as a cephalobrachial hypertension. So while waiting for surgery, as a temporizing measure, we will give some drugs, right? Sharon? Okay, because generally we feel whenever we discuss a cardiovascular case, whenever you say the history of medications being given, long-term medication given for a heart disease, we always only think of a left to right. But you should think of other conditions also. A coarctation may be given, some drug for controlling, at least partially controlling hypertension. Which are the drugs used in infancy with coarctation and hypertension to control blood pressure? In your experience as a 2.5-year-old experience as a postgraduate in Madurai Medical College, huge center with a huge turnover of babies. What have you used in your department? for a coarctation child waiting for a surgery. Not very sick, but in heart failure, but BP has a high BP, maybe even a child or an adolescent. Surya Prakash has any answer? Bhuvaneshwari?
Beta blockers, propranolol,
You are not very
blockers.
beta, exactly. Beta blockers. Yeah, beta blockers will be the first line of choice. Then you have the M-DOPA, which is very commonly used in pregnancy. That is also a very good drug. And you should know vasodilators, direct vasodilators are not used in coarctation. So then the examiner will ask you, can you think of any other congenital heart disease where drugs are given other than beta blockers are given, but some other congenital heart disease where beta blockers are given continuously before surgery? Sharon?
Hypertrophic cardiomyopathy, sir.
Okay, hypertrophic cardiomyopathy is not a congenital heart disease. What I am asking you is a congenital heart disease planning for a surgery, but some of these children may be on some drug, especially beta blockers. What is the likely candidate? Very simple. I mean, Tetralogy of Fallot, exactly. Tetralogy of Fallot with a history of a cyanotic spell, we will give prophylactic beta blocker. What is the beta blocker preferred, Surya Prakash? Propranolol. What is the dose of propranolol? What is the dose?
0.1 mg per kg.
How much?
0.1 mg per kg to 0.4 mg per kg.
No, we are talking about an oral beta blocker is given to prevent cyanotic.
1 mg per kg.
1 to 2 mg per kg per day, sir.
Okay, you are very miserly with the propranolol. The starting should be at least 2 milligram per kilogram body weight. Very important because they can again go for a cyanotic spell, no, inadequate doses. You can go even up to 6 milligram. Very safe drug, beta blocker in a Tetralogy of Fallot. You should remember. Only thing is just check your heart rate of that particular baby. So anyway, so you should, the lesson to be learned is that whenever we talk about a congenital heart disease on drug waiting for surgery or whatever, not only think of like decongestives, you should think of other drugs like used in coarctation, used in a Tetralogy of Fallot, all those things. Sometimes you have a congenital cyanotic heart disease, had a palliative shunt like a BT shunt, then the baby may be on a long-term aspirin. They will be giving low dose aspirin, 5 milligram. Again, that will generate another question in the examination that they will ask you, what are the indications for a low dose aspirin in pediatric practice? It is outside our purview of acyanotic heart disease, but still Surya Prakash can answer. What are the situations where low dose aspirin is given in pediatric practice? One, I have already told you.
Rheumatic heart disease, sir.
We are talking about low dose aspirin, 5 milligram per kilogram body weight. Rheumatic fever, the lowest dose for a maintenance will be 50 milligram.
Now you are seeing these diseases frequently.
Kawasaki disease. Okay. So what you should specifically say in the examination, you should be very clear. You are a postgraduate. You are getting the biggest degree in pediatrics in India. So you should respect that. You should respect yourself also. So you should say, I will say, I would suppose I was a candidate, I would say a Kawasaki disease in convalescence, not in an acute phase. Because acute phase, you will be giving a higher dose, like 30 or 40 milligram. So two indications. Kawasaki convalescing, modified BT shunt. Any other situation where you will give in pediatric cardiology? I will tell you. But I think probably you may not be aware. We do device closure, no? For ASDs, large ASDs and moderate to large PDAs. So for 6 months, we usually give aspirin 5 milligram per kg as a what you call as a till the endothelialization happens. So device closure. Then there is you should also be aware, because nowadays we should be aware of all these. There are some procedures like Glenn procedure, which is basically meant for a single ventricle physiology. There again, you will give either a low dose aspirin or some people will give even anticoagulant also. So these are the things you should be aware. Drugs used in congenital heart disease. So all of you should go back home and read about which are the drugs which can be given for congenital heart disease. But ultimately, all of them will require intervention, but still. Okay, go ahead. Child symptom improved with oral medication, right? Next slide.
Antenatal history, spontaneously conceived at 23 years of age, pregnancy confirmed at 30 days of amenorrhea by urine pregnancy test. Number of antenatal visits was 7, booked and immunized, iron and folic acid intake present, no history of fever with rashes or lymphadenopathy, no history of any drug intake or radiation exposure, no history of diabetes mellitus or hypertension during pregnancy. Antenatal scans done were said to be normal.
Yeah, stop at this. Stop it. Now I think Sharon knows my modus operandi, right? We stop at each slides, right? Okay,
Yes,
Sharon, this spontaneously conceived. What do I understand?
Sir, without
what
any undergoing any treatment for infertility, so it is.
Oh, I see. That is right. Okay. I thought that it's very interesting to have the spontaneous. Okay, because okay, that is right. Then you have 7 antenatal. So very well taken care of during the antenatal visit, right?
Yes,
and fever with rash and lymphadenopathy, you are thinking about a rubella syndrome.
Rubella.
Right, rubella. And naturally, people will ask you about the 3 most common congenital heart disease associated with rubella. That will go to Bhuvaneshwari. Bhuvaneshwari? 1, 2, 3 congenital heart disease in rubella in rank 1, rank 2, rank 3. Simple. Surya Prakash also can help her, no? Damsel in distress.
Congenital rubella. Sir is asking about rubella. Congenital
rubella.
Sir, I think they have some problem with internet
Problem.
connection,
Okay.
sir.
And Sharon
Sir,
will. Sharon will answer.
PDA,
Number 1
pulmonary
is PDA.
stenosis. Pulmonary stenosis.
Pulmonary stenosis, valvar or supravalvar?
Valvular, sir.
No. They produce a pulmonary artery branch stenosis. Very classic. Peripheral pulmonary artery
peripheral,
branch. Followed by 3rd is VSD, and the most common cyanotic heart disease is Tetralogy of Fallot. So, Sharon, you must be very clear about this. Number 1 is PDA. Number 2 is pulmonary artery branch stenosis. Number 3 is VSD, right? But suppose somebody asks you which is the most common cyanotic congenital heart disease in rubella, the answer is invariably should be a tetralogy of Fallot, right? So that is very important. Even in Down syndrome, the commonest cyanotic heart disease is tetralogy of Fallot. These questions are likely to be asked in the examination. Then you said something about exposure to radiation. See, recently, yesterday, I think the Russian forces took a Chernobyl nuclear plant, and you talk about radiation and all. So what is the kind of exposure to radiation which we ordinary civilians encounter?
Sir,
we are very X-rays. Basically it's all about X-rays. That is the thing. And it's better not to mention all this radiation business and all. And there is no history of diabetes mellitus, hypertension. That is a very important point. Antenatal scans were found to be normal. Suppose the mother says, "See, doctor, I have had 7 antenatal checks, had multiple ultrasound scans and all. Yet you people have not diagnosed a hole in my baby's heart." What will be your answer? How will you counsel that mother?
Sir, all congenital heart disease can be diagnosed in the antenatal scans.
No. That is not the question. My question is, I am a mother. I am very unhappy because my child has got a hole inside the heart. And you people have done how many? 7 visits I have come to the doctor. Many antenatal scans, you said plural. Multiple scans were done. But you have not picked up my baby's heart problem. What will be your answer to the mother? How will you counsel the mother? Simple. No? There is no catch. There is no catch, Sharon. It's a very simple. You are thinking about some catch. These cardiologists are asking some questions. So probably there is a catch. See, these are all scans. They are not targeted ultrasound. You know, most of them will be non-selective. So you have three kind of ultrasounds in pregnancy. The one would be the basic things like an ordinary antenatal non-targeted scans. Then you have the anomaly scan. Only very few people in India are fortunate to have this kind of anomaly scan. Then the third is when you suspect a heart problem and all, or you anticipate a heart problem, you will do a fetal echo. So you should tell the mother, see, most of these scans were basically obstetric scans. I am not sure whether your baby had or you had a targeted scan. That may be the reason why we have not picked up a congenital heart disease. Now, Sharon, again, that generates another question from me. That is, how will you classify the indications of fetal echocardiography? Because you may get a short note on fetal echocardiography. How will you classify, in theory, indications for fetal echocardiography?
If we suspect any chromosomal anomaly or trisomies.
So, correct. So it's a fetal cause, right? You suspect chromosomal anomaly. It's a fetal cause. Very good. That is one group. Another group.
Mother is taking any teratogenic drugs.
Very good. So that is maternal, right?
Previous child siblings or any first degree
relatives. So these are maternal things. Then sometimes what happens is that familial. Sir was saying about the
Doctor, can you please unmute yourself?
Sorry, I had been muted accidentally. So Sharon, so you should classify these indications into fetal, maternal, and familial. This is how you classify the indications of this thing. And I thought, I'm not sure whether you heard that how you should counsel the mother. You heard that? Because suddenly I find that I was muted. Anyway, go ahead.
Okay.
From my colleagues, Dr. Balasubramaniam and Dr. Bhuma, any comments at this point?
Previous slide, can you go, Sharon?
Yes, ma'am.
Can you go back to the previous slide? Antenatal.
Yeah. So, no, before that. No, before, if you're going behind, yes, previous, yes. So, no, after that, yes. One thing about the past history, I just want to highlight whether the child was having a failure to thrive. Because one of the major problems when the young infant fails to thrive, we think about cardiac problem, one is and other renal problem which is not undiagnosed, apart from as a secondary cause of failure to thrive, rather than blaming it as a primary nutritional problem. So failure to thrive and whether there was any developmental problem, probably you'll highlight on it later, we'll wait and see. And another thing, how many episodes in that year it would have been better, and as Sir told, and what are the drugs he discussed in detail. And next slide. And antenatal history, we have told what are the drugs with directly related to your case. Probably it is a septal defect you are dealing with, the increased volume overload and recurrent respiratory tract infection. Cyanotic will be asked for us. So far we have got into it. So what are the drugs you are interested in asking exposure in the mother?
Ma'am, anti-epileptics like phenytoin, valproate, ma'am.
Correct. Good.
Then other drugs like amphetamine, trimethadone can cause VSD, ma'am.
You should also ask for lithium also has a direct effect on the developing heart. And as you all know, like these drugs, especially when they have a previous history, mother on anti-epileptics, then because of the longer exposure will be here. And you also ask for diabetes mellitus and hypertension. How is hypertension related to a heart disease?
Babies of hypertensive mother could be IUGR preterm babies, ma'am. Preterm babies, there is a risk of patent ductus arteriosus. Ma'am.
Very good. Okay.
Very good. Very good. Super.
Right.
Now, Sharon, you've done very
And,
well.
And if you say like abnormalities in the antenatal scan itself, what are the abnormalities you want to look for pertaining to cardiac problems? And if so, what?
Most commonly we get echogenic foci, ma'am.
Yes.
Most of them they don't point towards any major anomaly, ma'am.
Good.
Other than that, pulmonary stenosis, TAW physiology could be made out, ma'am, from the antenatal
Yes,
scans.
Truncus arteriosus, midline defects to some extent we can say. And another thing is you can also look for other chromosomal abnormalities like increased translucency and absence of the nasal bone, which can, as far as told, Down syndrome, which is more common among the chromosomal problems, which is associated with the congenital heart disease also. Yes.
Okay, ma'am.
Sharon,
And spinal
okay.
problems also you have to look for.
No.
Yes.
Okay, ma'am.
Sharon, what Madam highlighted was what you answered in a different way. Madam, what she anticipated was, the question was basically, if you have a heart disease on antenatal evaluation, what are the conditions that you should expect and look for in an antenatal scan? That is where the midline lesion, truncus, and Down syndrome with AV canal, right? And that kind of thing. Lithium, what does it produce in the baby?
Epstein's anomaly, sir.
And any other lesion which can be produced by lithium? Difficult answer, but you must think of a tricuspid valve. So lithium has a fascination for tricuspid valve. So naturally, what will be the second cause?
Tricuspid atresia.
Exactly. Very good. So these are the two lesions. So you have an additional point in the examination. You can try to impress the examiner by saying that tricuspid atresia also can be caused by what's
Lithium.
Epstein anomaly. Okay, go ahead.
Yes, proceed.
Natal history, full term, normal vaginal delivery, baby cried at birth. Baby was admitted on day 1 of life in view of respiratory distress. During the hospital stay, the mother was informed that they were suspecting some obstruction of the nasal cavity, and some imaging was done which ruled out the obstruction. The baby was discharged on day 3 of life.
So what do you think, like that's an obstruction to the nasal cavity requiring an imaging?
Ma'am, it could be a choanal atresia, ma'am.
You do an imaging for that, you just put an tube and see and find out. What else could be? Because they'll say like nasal cavity, probably they wanted to rule out TEF.
Yes, ma'am, could be, ma'am, tracheoesophageal fistula or
So what
narrowed.
will come to your mind when you have a child with a respiratory distress in day 1 of life, normal vaginal delivery, term baby, cried at birth with 2.7 kg.
Ma'am, meconium aspiration syndrome, ma'am.
Okay.
TTL.
2.7 kg, yeah, okay. But it's vaginal delivery and there is no meconium stain liker. Then also you think of meconium aspiration syndrome.
No, ma'am. Even sepsis could cause respiratory distress, ma'am.
That is indirectly.
Congenital surfactant deficiency.
Congenital surfactant deficiency, yes.
Congenital diaphragmatic hernia, tracheoesophageal fistula.
Yes.
Choanal atresia. Since it's a term baby.
Yes, term baby.
Transient tachypnea of newborn also a possibility, ma'am. But it is a normal vaginal delivery, it's less likely.
Yes. Diaphragmatic hernia.
Other causes.
Diaphragmatic hernia.
Patient with a scaphoid abdomen with respiratory distress at birth.
Yes. So, and of course, our severe forms of congenital heart disease are the critical heart diseases can also present with respiratory distress at birth. Yes. Sir.
Sharon. Yeah, Sharon.
Sir.
See, the birth weight is 2.7 kilogram, which is a normal birth weight, right?
Yes,
low birth weight is less than
2.5 kg, sir.
2.5. So in Tamil Nadu, what is the percentage of babies born with a low birth weight babies? Is it important for a pediatrician?
Yes, sir.
Yes. What is your impression or knowledge regarding percentage of babies in Tamil Nadu having birth weight of less than 2.5 kg? Give me an approximate value.
15 to 20%.
15 to 20%. Absolutely correct. Very good. In Kerala, is it likely to be lower or higher? It is more or less the same. It's more or less the same, but it is slightly, both Tamil Nadu and Kerala have a low birth weight percentage, much lower than the national value. Not much lower, lower than the national value. Okay, you go ahead. We have 59 minutes more. We'll go further. Right. Sharon, you can continue.
Okay.
Yeah.
Postnatal history was uneventful. No history of cycle of forehead sweating during the postnatal period. The baby was exclusively breastfed till 6 months of age.
Yes, go ahead. Please. Yeah. Go ahead. Sharon?
Sir, my slide is not moving.
Oh, I see. This is developmental history. I can see that developmental history. Developmental history, just give us an idea. Gross motor, what is the, is it okay?
Sir, milestones are appropriate for age, sir.
Correct. Both motor as well as intellectual, no? Language, everything you feel it is normal. Okay. So what is the relevance of knowing? Can you hear me, Sharon?
Yes, sir, I can hear you, sir.
Okay. What is the relevance of developmental history in a baby with a suspected congenital heart disease? Give me examples.
Sir, usually these children will have motor developmental delays, sir, because of
Which children? Which
PCF.
cyanotic or acyanotics?
Acyanotic, sir, because of
cyanotic. Cyanotics will have a motor delay, not acyanotic. Okay, then what else? What will be the, whenever you have a congenital heart disease and a global developmental delay, what are the possibilities that a pediatrician should think of? Common things. Suppose there is slightly funny looking baby with a VSD like percentage. Suppose you have a elderly mother with a, nowadays you get Down syndrome. Always think of a Down syndrome because it is 1 in 700 births. It's a very important disease for a pediatrician. Then Rubella syndrome. There will be can be a global developmental delay. So when there are many other chromosomal syndrome also, there can be a delay. So you should think like that. So development is very important, and that is one group. So syndromes with the congenital heart. So that is one group. Another is where the motor delay is dominant, which is usually in a congenital cyanotic heart disease. They may have usually intellectual delay may not be there. And there may not be a global delay in ordinary left to right shunt. There may be a failure to thrive, but not a developmental delay, unless it's a part of a syndrome. Okay.
So can you see my screen?
No, I can see many umbrellas.
Many umbrellas only are seen, but your slide is not coming.
No, slide is not there.
Yeah. You can try. We will wait. We'll wait. Or if you have the
Your
paper,
screensaver is there. Your screensaver is there. I think. Oh yeah, PowerPoint.
PowerPoint. I think you have to again. Yeah, we'll wait. Meanwhile, while we are waiting for Sharon, Surya Prakash and where is our Bhuvaneshwari has disappeared.
She has come to help, sir.
Oh, I see. Oh,
she has come to help, sir.
Sharon. So, Surya Prakash, what are the causes? What are the congenital heart disease associated with the preterm delivery? Preterm baby and congenital heart disease. Very simple question. Just to yeah.
Patent ductus arteriosus, PDA, sir.
Patent ductus arteriosus. Okay. Any other congenital heart disease which is associated with the prematurity? If they ask you, they should say a VSD. A muscular VSD is slightly more common in epidemiologically, it is more common in a preterm baby, right? So these are the two conditions, but not in a low birth weight. So here it is. And now Surya Prakash, Yeah, you have come back. One more question. What is the relationship between adult onset heart problems like diabetes, hypertension, coronary artery disease, and low birth weight? Is there a link between low birth weight and cardiovascular diseases in adult? You are aware of it? Yes?
More from develop metabolic syndrome. Cardiovascular complications are more common in the child born with.
Okay, what is that hypothesis called? Somebody's name is there. Very important for pediatricians and also for cardiologists. So it's very important for a pediatric cardiologist, for me. Anybody? Anyway, Bhuvaneshwari, we will ask later. No, it doesn't matter. Okay, doesn't matter. Then we'll see. We'll see anyway. We'll come back to that.
I can remove your mark. Expo. Yeah, we have an echo.
Okay, Surya Prakash, we are back to the developmental history. She says that everything is okay. I mean, there is not much of a delay. Socioeconomic history. Sharon? Okay, go ahead. Continue. Yeah. Again, it is gone. So now I will again continue to ask Bhuvaneshwari has come. Bhuvaneshwari, there is a link between low birth weight baby. While we will keep Sharon away from the stress. Sharon, relax and go back to your slide and come back. Till then, we will I will interact with Surya Prakash and Bhuvaneshwari, right? So Bhuvaneshwari, what is the hypothesis mentioning the link between low birth weight baby and adult onset heart disease called? There is somebody's name is there. Very important, I think. I mean, even if you don't know, right, doesn't matter, but you should go back and find out. Sometimes it is asked in DNB pediatrics theory paper.
What does the dog do?
So you heard about Barker hypothesis? No, not yet. Okay, we will still time for you to read about Barker hypothesis. Now, again, Surya Prakash, I like Surya Prakash because the name, no, I remember, it reminds me of Dalavati. Surya. Surya Prakash, how many times you have seen that Dalavati? Have you seen Dalavati? Rajinikanth movie? Huh? Obviously, yes. How many times?
One time.
Only once, I see. Anyway, doesn't matter. Now, but the point is, our Sharon was discussing Al-Kappa, mentioning Al-Kappa many times. What is the problem with the Al-Kappa? Why is it harmful to the baby's heart? Surya Prakash and Bhuvaneshwari together you can say, but why baby get harmed? They get heart failure, all those things with Al-Kappa.
Myocardium will receive the deoxygenated blood from the pulmonary artery.
Now, Bhuvaneshwari, suppose that is the major reason. Now, suppose you have a transposition of great arteries, TGA, right? What will be the saturation of aorta in the TGA? Very low, like 60-65%. So that is perfusing the coronary arteries. So the baby has hypoxemia that is there, but that does not produce heart failure, that does not produce myocardial infarction. So the heart is capable of managing with a very low saturation. So that is obviously not the cause for heart failure and angina in Al-Kappa. You understand? You understood? That is, it is very important to understand that. It's a very important point for a pediatrician to know that Al-Kappa the problem is not because of the hypoxemia alone. What will be the factor? Surya? Have you heard about Steele phenomenon? Steele, STIL? No, like Steele. See, what happens is that because you have Al-Kappa, left coronary arteries supply the major part of the heart, right? And that is originating from the pulmonary artery, so that there is a collateral formation between these two. And there is anyway, you go back and read about the mechanism of problems in Al-Kappa. That was a filler only. Now we are back to Sharon. Immunization. Okay. So socioeconomic history, right? Yes, go ahead. Sharon? Sharon?
Sharon, you can proceed.
You can proceed, Sharon. No, hello?
Surya, you can go and help. It's a problem in the net, I think.
Yeah, I think that's a problem. I think it's okay.
Yes.
I mean, relax, Sharon. And Bhuvaneshwari, you are here. Okay.
Bhuvaneshwari.
Yes, sir.
So while Surya is helping her, I will ask you some questions regarding this slide. This concrete house, 4 rooms, separate sanitary facility, municipality, drinking water, and father's education is post high school diploma. What about the mother's education? It's very important. Maternal education.
Yes, sir.
Sharon is back.
Yes, sir.
So sorry for the interruption.
Yeah,
sir.
No problem, no
don't worry.
problem.
How can you be so? You should feel sorry. No, it's okay. No problem. No, what I want to ask is, you have deliberately omitted education status of the mother. No, one of the most important single factor determining child survival all over the world is the maternal education status. And you have forgotten. Have you forgotten? And you are a lady, no? You should have a you should know and
More
never have a gender
thinking-
discrimination.
Thinking more towards that income, sir. That's why.
Income, yeah, I understand, sir. So what is the education status, Sharon?
Sir, she has studied up to 12th standard, sir.
Well, standard. Okay. And the boy is post high school diploma. Now, you know what happens in Kerala, Sharon? A majority of parents, middle class or lower middle class parents, we ask questions. Usually, the mother is a graduate and the father is usually a post high school, etc. That's an interesting phenomenon in Kerala. Occupation is a shop owner. Okay. How many children? You did not tell about them.
There are 2 children, sir. Elder sibling, a 6-year-old female child, and this child is 21 months old male child, sir.
And it is always better to say, rather than female child, looking it like an object. You should say a girl, no? 6-year-old girl, 4-year-old boy, or a 4-month-old baby boy. That would be better than saying a female, male, and all the male child. It is less personal. Okay. So it is according to modified Kupaswamy classification, right?
Yes, sir.
Okay. When was it last modified, Sharon? When was Kupaswamy last modified?
2021, sir.
Very recent, right?
Yes,
Very
sir.
good. Very good. Super. Great. I mean, practically no postgraduate in our department will answer that. Good. Next.
Nutritional history, there is a calorie deficit of 50 kilocalories and no protein deficit.
Okay. So the point you are making is that the energy requirements are met, protein requirements are met. But according to you, in the history at least, there is a failure to thrive, which will be confirmed by your physical examination. Go ahead. Okay.
Summary, 1 year, 9-month-old male child presenting with recurrent respiratory tract infection with forehead sweating and inadequate weight gain without cyanosis with normal developmental, most probably a case of acyanotic congenital heart disease with left to right shunt in failure. So I would like to
proceed
with a serious examination to confirm my diagnosis.
Okay. Go ahead. Oh, we have only reached the examination. Okay, go ahead.
On general examination, the child is alert, awake, tachypnic, no cyanosis, no sacral edema, no pallor, no icterus, no lymphadenopathy.
Okay. Go ahead. Next.
Sharon.
You can go for the next slide.
Next slide. Yes. Yeah, I think maybe it's stuck maybe. Again, do you remember the findings? Then you can say also.
Sir,
have you?
Sir, head to toe examination. So my slide, tell it, sir.
Okay.
Yeah, you proceed, doctor.
Sir, head to toe examination. there were no dysmorphic facial features except for bad-shaped ears and low-set ears, sir. Then vitals, the child heart rate is
Some abnormal here. Okay. then.
Harrison sulcus present, sir.
Okay, right.
Vitals, heart rate 150 per minute, tachycardia present, regular in rhythm, normal in volume, no specific character, no radial
No,
or
you cannot say heart rate and you say normal in volume. You should say pulse rate, right? Heart rate is different from pulse rate. Do you agree or not agree?
Yes, sir. Yes.
Yeah, it is. You should say pulse.
Okay,
so you
sir.
start with a right radial pulse, in the standard way. So you should start by saying right radial pulse, 150 per minute, regular in rhythm, normal in volume, no specific character, no radial or radio femoral delay. You're talking
all
about the pulse,
peripheral
not the
pulses
heart rate.
were equally felt.
Okay,
Respiratory.
no, stop at this point.
Okay.
You said, so what, sometimes you get a discrepancy between the heart rate and the pulse rate. What is that called?
So pulse deficit, sir.
Okay. Which are the situations where you get a difference in this kind of?
Sir, atrial fibrillation.
Or frequent ectopics. But more of pulse deficit is seen in atrial fibrillation. But fortunately, AF is practically unknown in a child below 10 years of age. Okay. You talk about respiratory rates.
Respiratory rate 70 per minute, regular abdominothoracic type. BP 90 by 60 millimeter of mercury, equal in all four limbs. Saturation 98%, equal in all four limbs. Capillary refill time less than 3 seconds. Central pulse 3 plus, peripheral pulse 2 plus, temperature 90 degree Fahrenheit.
We'll stop at this point, right? Okay. Dr. Bala, you want to? Now, upper limb BP is 90 systolic. Lower limb BP is what is
90, 66, 96,
okay,
66.
it's okay, fine. Saturation is 98%. So basically, we are talking about a cyanotic heart disease. Perfusion is okay. Temperature is also fine, right? So you have a tachypnea, right? Tachypnea and tachycardia is there, right? In a 2-year-old child, right? Okay. Now you said radial, and radiofemoral, right? So can you give me 3 causes of radial delay? It's a very, very, very dangerous statement in the no, dangerous is potentially harmful because nobody expects you to take all these things. But if you say radial, people will ask you. They will be tempted to ask you causes of radial delay. Then you can say the right answer. You will be great. It will be great, like your Kupuswamy.
So if the origin of the left subclavian could get a radio.
Origin of the
the left subclavian artery proximal to the ductus connection, sir.
I cannot understand that.
In which condition, doctor? In the condition, in which condition we get a radio?
Coarctation of
that's
no,
what. Yes.
That is coarctation with the. Is it before the subclavian or after the subclavian?
Before the subclavian.
Before the subproximal.
So it's a pre-subclavian coarctation. The usual coarctation is post-subclavian. So one is a pre-subclavian coarctation. Very good. Next. Any other very important rare congenital heart disease? I will give you a clue. There is hypercalcemia also in that child. Slightly funny looking face.
Supravalvular aortic.
Exactly. Supravalvular aortic stenosis. Great. And then very rarely in older children, adolescents, you can have Takayasu also. You can have a differential this thing. Radial delay. Very good. You have passed that. You have crossed that trap. Okay. Go ahead.
Anthropometry, weight 8.6.
Now I want to ask my colleagues in pediatrics, all my colleagues, including Srinivasan sir. I thought it would be better to start with anthropometry or a growth, because I think basically what differentiates a child from an adult is that growth, right? So I think growth should have come much ahead of your general examination, because especially in this baby, you are saying that there is a significant failure to thrive. And very interestingly, you have a normal calorie intake and protein intake. So I think, I think it should be before. What do you say, sir? Dr. Bala and Dr. Bhuma?
Yes, actually,
Yeah.
Yes, sir. So we normally divide general examination into 4 parts. Sir.
Okay.
General examination, proper general examination pertaining to particular system, and anthropometry, vital signs. So, as you said here, the problem is that we can give more importance to anthropometry.
The growth assessment. Okay. So, okay, comment, Sharon. You give me you are giving me the values. Okay, 8.6
against 11 kg between minus standard deviation and minus 3 standard deviation according to chart.
Some degree of malnutrition, right?
Length 80 centimeter against 83 centimeter, which is between minus 2 standard deviation and head circumference 45 centimeter, which is appropriate for the age. Mid upper arm circumference 13 centimeter, which falls in moderate malnutrition according to the Shahid tape, sir. It falls in the yellow zone, sir.
Length, I am very curious to know your comment. You are not commented on length.
Sir, there is no stunting, sir. Normal, sir.
So it's normal. So length, you feel it is normal. Weight is a little on the lower side. Head circumference is again normal. How many standard deviations should be away from the mean to say microcephaly?
3 standard deviations.
Exactly.
Sir.
Very good. So the only situation where in all this growth assessment, 3 standard deviation is taken is a head circumference. Very good. So these are the usual mistakes people commit postgraduates, right? Good. And you should say in many syndromes you can expect microcephaly like rubella. So head circumference is very crucial, right? Good. Good, Sharon. You're doing very well.
So shall I go to the next slide? Sir?
Yes, definitely.
Proceed.
CVS examination on inspection, chest wall asymmetry present, precordial bulge present, apical impulse seen over precordium below and lateral to the left nipple, left external pulsation present, no other chest wall deformities, no scars or sinuses or dilated veins, trachea appears to be in midline.
Palpation.
Yes, you proceed.
Proceed. Palpation is more important, right? Because
on
basically
palpation, tracheal position confirmed. Felt in the left 6th intercostal space, 1 centimeter lateral to the mid-clavicular line. It is hyperdynamic in nature. Thrill present over the lower left sternal border. Parasternal heave of grade 2 present. Palpable P2 present in the left 2nd intercostal space.
Okay, we'll stop. This is a very important slide. So sometimes actually the palpatory findings are very crucial. It is as good or even as better than the auscultation. So you go back to the previous slide.
Palpation.
Slide means your palpation slide.
Palpation.
Palpation.
Anyway,
yeah,
sir, the slide is not moved.
Yeah, that's okay. Doesn't matter. I have noted it down. I remember this.
Parasternal P2 palpable and
4 points are there. No, there is a big heart. No, cardiomegaly is there. The hyperdynamic circulation, right? So what does that mean? So this cardiomegaly is due to right ventricle or left ventricle? Sharon? Is it because
left
of
ventricle, sir.
Left ventricle? Is it because it is a hyperdynamic? Is it because of pressure overload or volume overload?
Sir, volume overload, sir.
Volume overload. There's no catch. It's a volume overload, right? So that is why it is more or less helps you in making a diagnosis of a post-tricuspid left direction. So there is significant cardiomegaly, LV apex, and a volume overload. So you get a lot of information from the one point. Then you should also say whether there is a thrill or not at the apex. For example, you have an AVSD, atrioventricular septal defect, that can be severe MR with a VSD. So that MR can produce a systolic thrill. So it is still possible in an infant. Then you said there is a thrill in the left sternal border, right? Left lower or upper?
A lower sternal border.
Lower sternal border. Okay, low. So when you have a left lower sternal border, what is
can you hear me, sir?
Yeah, I can hear you.
But your slide alone is not visible.
But you are audible. Don't worry. I can see you. I can hear you. Everybody can hear you. So lower sternal border, a thrill. So what is the
bother much about the slide, doctor. You have finished your presentation. No problem. Just you can discuss, come for discussion.
Correct.
Yes.
So what is the most likely cause of a thrill? Systolic thrill at the lower sternal border?
Sir,
No.
ventricular septal defect, sir.
Yeah, ventricular septal defect. Don't look worried and all. Nothing happens here. So you have a thrill at the lower sternal border. It is due to AVSD. Now Surya Prakash will help you. I will ask you at least 2 or 3 causes of a thrill in the left upper sternal border, while Sharon is
The
recovering.
pulmonary hypertension, pulmonary stenosis.
No, be very careful. I am asking you the cause of a
Thrill in
systolic
the
thrill
upper
in the
sternal
left upper sternal border.
Sir, PDA.
PDA. Yes, correct. Pulmonary stenosis. No, why are you saying pulmonary hypertension? Pulmonary hypertension will not produce a loud murmur. If you have a loud murmur in any situation, it is not part of the pulmonary hypertension. So upon whatever you say the right, all the other right answers you say, if you include PAH as a cause of thrill at the left upper sternal border, there will be trouble. So you should only say patent ductus arteriosus and pulmonary stenosis. Any other possibility, Bhuvaneshwari, in the upper sternal border, mid upper sternal border? Suppose there is a particular kind of VSD which can produce a thrill in the upper sternal border. Any location of the VSD? There are 4 types of VSD, Bhuvaneshwari.
Membranous, macular, inlet, and outlet.
Okay, so between membranous and outlet, Bhuvaneshwari, between a membranous VSD and an outlet VSD, which VSD is logically which should cause a thrill?
Typical VSD.
No. I am not asking you, Surya. You are confusing poor Bhuvaneshwari. Bhuvaneshwari was saying that there can be a membranous VSD and a outlet VSD. I am giving you the stress. So between outlet VSD and the perimembranous VSD, which is likely to cause a thrill in the left upper sternal border?
Perimembranous outlet PSD with A.
No, there is nothing like a perimembranous outlet. It is either perimembranous or outlet. Outlet, what is the other name for outlet VSD?
Subpulmonic.
Exactly. Okay. Subpulmonic VSD is capable of producing a systolic thrill. Okay. Now, again, back to Surya. Suppose you have a thrill at exactly in the mid-sternal border, not in the upper sternal border, not in the lower sternal border. Can you find any cause in a child or adolescent? Could be VSD also, but apart from VSD.
Ventricular septal defect, HOCM.
HOCM, correct. It can be due to an hypertrophic obstructive cardiomyopathy. So that is the point. Then she has mentioned LPH grade 2. Sharon, can you hear me? Sharon? Okay. There's a problem.
Actually, right? She was disconnected.
Okay. Okay. So she cannot hear us also. I think it's okay. Now, I hope that other postgraduates are hearing this. I'm not sure. Yeah. Surya, LPH grade 2. What do you mean by that? What does she mean by that? You can help her out. What is the implication of grade 2 LPH? What is meant by this? What is meant by LPH grade 2?
So visible, palpable, and obliterable. It is classified into 3 grades. Sir. Grade 1 visible, grade 2 visible, palpable, and also obliterable. Obliterable. Grade 3 visible, palpable. It is not obliterable.
Okay. Now tell me about grade 1 LPH. Be very careful. LPH grade 1. What is it? You tell me. You educate me on this.
How will you do?
How
will you do? That's what sir is asking.
Is it a palpatory finding or a inspection finding?
Inspectory finding, sir.
No. How can LPH be an inspection finding? See, Surya, there is a problem with Surya is that you are very fast, very quick. Sometimes, being little slow is always better. No, slow and steady wins the You will anyway definitely win the race, but still safer.
I always used to say, don't be fast, sir. You
No, I don't be
identified
fast.
within 1 hour, sir. You identified Surya.
Like he is very enthusiastic. That is the problem. When you become enthusiastic,
Yes, sir. Yes, sir.
So be aware. So I think be like Sharon. Anyway, I am not comparing all these people, but anyway, Surya, can you hear me, Surya?
Yeah.
Yeah. See, LPH is a left parasternal heave. LPH is a palpatory finding. There cannot be any doubt about this. You understand?
He's enjoying your comment, sir.
Hello?
He's enjoying your comment.
Okay. So grade 1 LPH is a palpatory finding. Catch, but then there's a catch, the examiner will catch you there. It's very delicate situation. Right? So that is the point. So you have a significant LPH is there. And P2 is also palpable. Now, Bhuvaneshwari, can I ask you one question?
Yes, sir.
Yeah. Suppose you have a palpable pulmonary artery on second space, but there is no P2 palpable. Can there be such a situation? You feel that there is a pulsation of the pulmonary artery, but P2 is not palpable. Can you find that condition in any situation? I mean, that particular situation. Generally, you happen to have PAH where your P2 is palpable, pulmonary artery is also palpable. But sometimes pulmonary artery is palpable, but P2 is not palpable. Is there any situation? Even Surya
It develops pulmonary vascular obstructive disease.
No, that is PAH. Then P2 will be palpable. See, pulmonary vascular occlusive disease is nothing but a very severe pulmonary hypertension. That you have both PA and P2 are palpable. Or even only P2 is palpable. But what I want to know is where can you get a PA palpable? Pulmonary artery pulsations are palpable, but P2 is not palpable. The logic is that there is no pulmonary hypertension. So can you give me any condition where pulmonary arteries are dilated, but there is no pulmonary hypertension? That will give you that answer. Shall I tell? For example, if you have a post-stenotic dilatation in pulmonary valvular stenosis, PA will be dilated. P2 will not be palpable. Why? There is no PAH. There is something called idiopathic dilatation of the pulmonary artery, where you have a pulsation of the pulmonary artery, but P2 is not palpable. Why? Because PA is not under pressure, right? So these are the situations you should know as this. So anyway, according to Sharon, there is significant cardiomegaly of LV type, LV volume overload type, and there is the left lower sternal border almost pointing towards a single diagnosis of a VSD. And then there is evidence of pulmonary arterial or pulmonary hypertension. So you have a significant VSD with significant cardiomegaly and pulmonary arterial hypertension. Agreed, Surya, right?
Yes, sir.
Now, suppose I say the thrill in this baby is not going smoothly with the other two findings. Will you agree with me or not agree? What we have is a big heart, hyperdynamic heart, LV heart. And also we have a significant right ventricular hypertrophy. So we are dealing with a biventricular hypertrophy, right? Due to a possible VSD, because there is a thrill, etc. Now I feel that thrill is not going smoothly with the other finding. What could be the reason why I am saying that? Any of you, Surya? See, the point, Surya, is that, or Bhuvaneshwari, is that if you had a thrill that is a 4/6 murmur, it's a loud murmur. So when you have a VSD and a loud murmur, it means it is a restrictive VSD. You classify physiologically VSD into a restrictive VSD or an unrestricted VSD. Generally, unrestricted VSDs do not produce a thrill. So here the thrill means you are dealing with a restrictive VSD, which can be either a small VSD or a moderate VSD, right? So moderate VSD should not produce an apex beat at the 6th left intercostal space in the, and almost like at the anterior axillary line. So there is a discrepancy between this, but you have to accept it. Everything does not go in a theoretical fashion, right? But you should understand that. Now, our auscultation, is Sharon back in circulation? No. Are you sitting near her?
Surya,
Then you can.
Surya, you know that.
Yeah, you know that.
You can
Exactly.
proceed.
You can proceed. Correct. Maybe even Sharon can come if they are closer.
Ask her to come here, Papa.
Yeah. Correct.
Ask Sharon to come, Surya. You know the auscultatory finding.
Sir, shall I share the screen, sir?
You can tell even.
Surya.
Or ask Sharon to come.
Okay.
So your computer.
You can start say and you can ask Sharon to come. By the time Sharon comes, we will ask her question. Right. Auscultation, Surya.
Auscultatory finding alone. Surya, what is the auscultatory finding? You can tell now. Auscultation.
Sir, is it audible, sir? Sir, one
Yes,
minute,
audible.
share the screen.
Audible. Surya,
Sir, I
you
am
are
sharing
audible.
the screen, sir. Okay, sir, I am sharing the screen from my laptop.
Sir, Surya, if you have problem in hearing, please switch off your camera and use only the voice mode or the screen mode. Then it will be better.
I know
Okay,
Surya is getting that slide. Okay. Good. Reaching somewhere. Go ahead. Good.
Yes, more or less.
No, before that.
Auscultation. Yes.
Right. Auscultation. Right.
Sir, now
Yeah.
it's visible, sir.
No, can you hear me? Then I will read out. Then there will be no problem because there is some problem with Surya's audio. This thing also. So I will read out that auscultation. Sharon has. No. I will read out because I will offer some comments on this. Can you hear me, Surya? You say yes or no. I will read out. Don't worry.
Yes, sir. It's a hearing. It's audible to me, sir, but my voice.
Okay, doesn't matter. The point is auscultation. Sharon has started with the tricuspid area. That's a very interesting thing. I will comment on this because generally you said this is the MBBS kind of thing because you go for each area and discuss. Now I don't think we do like this now. And secondly, anyway, you don't start with the tricuspid area in the beginning. You should either start with an apex or start from the aortic area. You start from the aortic area, go to the pulmonary area, come down to lower sternal border, etc. Or start from the apex and go upwards and to the left, right. But generally nowadays, what we do is you comment on the heart sounds. For example, S1, S2, S3, S4, if there are any. Then you comment on additional sounds in systole or diastole, and finally go to the murmurs. Otherwise, what will happen is the same thing has to be read again and again. But anyway, it is now that it is there, I will read out. There is a pansystolic murmur or grade 4/6 heard over the lower left sternal border. The point here is this particular murmur or any systolic murmur in the lower sternal border can be either due to a tricuspid regurgitation or a VSD. But when you are expecting a large VSD or a moderate VSD, and you are stating that in a tricuspid area there is a pansystolic murmur, it is confusing because one is reminded about a tricuspid regurgitation. Generally, tricuspid regurgitation do not produce a
loud left sternal borders.
Yes, told the
left sternal border.
And secondly, I think always safer to start with the first heart sound. Suppose you say first heart sound is heard normally. Right, that is one. Then S2 is very important. He has said S2 is heard, wide and variable split is the second sound with a loud P2. Very good. So I will modify this. So according to this slide, I will modify it only. That is, I will not change the message. So S1, that is first sound, is normal. Second sound is split, wide, variable with a loud P2. And you have not mentioned anything on S3 or S4. Now, Bhuvaneshwari, if suppose you get either S3 or S4, Which is likely in this patient? Initially.
LVS S3,
S3.
sir.
LVS3 is okay. Where do you get LVS3? Which area?
Mitral, sir.
Yes, apex. It is from the apex. So S1, S2, S3.
Mitral area.
Right. Okay, right. So then you go to any additional sounds in systole or diastole, like a click, because sometimes in a PAH situation, in this particular patient, there can be an ejection click may be present. But you should mention that, very important. Then you should look at any diastolic events like S3 we have already mentioned. So that is that. Then only you come to the murmur. So you start with the systolic murmur, then go to the continuous diastolic murmur. So you have major finding of a pansystolic murmur heard at the left lower sternal border. And that murmur is heard with reduced intensity at the mitral area. Very good. So you are committed to a ventricular septal defect. Then you are written also that ejection systolic murmur is heard at the pulmonary area. I think you should comment on the grade also. So Surya knows this case, no? So what do you think was the grade in this particular child? Was grade 2 or grade 3? Surya? No. What I want to know is, was it a grade 2 murmur or a grade 3 murmur or a grade 1 murmur?
Grade 3 murmur.
You think it is a grade 3 murmur. So what are you saying is that it's a loud murmur. Okay. This loud murmur, that is grade 3 murmur, is due to what? Initially, you think the pulmonary hypertension will produce a grade 3 murmur. It is wrong. See, you will never get a loud murmur in a pulmonary. You should go away with that very important finding. You will not get a very loud murmur in pulmonary hypertension. So if it is this ejection murmur is due to pulmonary hypertension, it is most likely to be due a grade 2. So if you have a grade 3 murmur in an otherwise VSD, you can even think of a mild pulmonary stenosis. But anyway, that is another area. But I have a feeling that this ejection, because always I find that my postgraduates are much better than me in grading, in the sense that their murmurs are louder than my murmurs. So that is possible. So then any other murmur? No other murmur. What murmur did you expect, Surya, in this patient? Very important murmur.
Mid-diastolic murmur can be here.
Yes, at the apex. Oh, did you hear this? No.
No.
No. Okay. Because that is very interesting, because a huge heart LV and all, you are not getting a mid-diastolic. So what you should do in the examination is that, if it is, let's be very honest. So if you cannot hear an MDM, but you still feel there should have been an MDM, you tell the examiner that, sir, I have auscultated for a MDM at the apex, but I cannot hear it. So which means that you know what to look for, right?
Okay, sir.
Okay. Then an older child, above 5 years or so, you should also look for an early diastolic murmur of an aortic regurgitation. So that is also important, right? So what the examiner wants is whether you know what to look for. Even if you miss some finding, it doesn't matter. So if I were a postgraduate currently, I would say I would rewrite this as a S1. First sound is normal. Second sound is widely split variable with a loud P2. No S3, no ejection click, and a grade 4/6 pansystolic murmur in the lower sternal border. Heard less intensity in the apex. There is a grade 2 or 3 ejection systolic murmur at the pulmonary area, and I could not find a mid-diastolic murmur. Right. Now, Bhuvaneshwari, what is the implication? If it is VSD, what is the implication of a wide and a variable split?
Wide split because aorta closes first because of the early closure of the aortic valve. There will be decreased. The blood in the LV reaches right ventricle due to the shunt. So aorta closes early, but pulmonary closes late due to increased flow across the due to pulmonary congestion and pulmonary hypertension.
Okay, I mean, essentially what you can say, start by saying is that it is wide because A2 is early. Don't mention about E2. So as you said correctly, what happens in a large VSD is that as soon as the systole starts, LV ejects blood into the aorta as well as into the right atrium. So the LV ejection time is very short. So naturally, when the LV ejection time is very short, naturally following that you have a diastole, and what will happen? Basically, A2 will be very early. So early A2 and normally placed to P2. So you will have a wide split. And because there is no ASD, it is a variable split, right? And that is very important in pediatric cardiology because any VSD, even with a severe pulmonary hypertension clinically, if there is a split S2 in a VSD, it is operable. Very important. The one very important physical finding in a VSD with, even if you feel this VSD has a severe pulmonary hypertension, if S2 can be heard well split, it is operable. There is no pulmonary vascular occlusive disease. That is very important. And MDM also, we are very happy. Now, Surya, this particular child nearing 2 years with the PAH and all, and you are thinking about the possibility of a surgery. At this particular point, without seeing an X-ray and ECG, do you think this is operable or not operable?
Operable.
It is very much operable. Now, all the findings are in favor of. Sharon is back in business. Okay, next, Sharon will go to the diagnosis or other findings, respiratory and all those, quickly, because we have only 12 minutes. Sorry, I think we took a little more time with the history. Doesn't matter. Sharon, continue.
Sharon available? Yes.
Yeah, Sharon. You can read, you know the findings. Then you just tell me, now let's be very informal. It's only 10 minutes now. Don't bother about the screen. Bala sir is saying no, don't bother about the screen. You tell me what are the other, is there any positive respiratory finding, any neurological finding, abdomen, whatever, quickly. Because we want to just see X-ray and ECG, then we will finish. Sharon, don't bother about
audible
PowerPoint presentation.
Sharon, audible? Sharon?
The respiratory system, the child is active with subcostal and intercostal retractions. So,
Connection,
If the other persons have already seen the case can present, we can proceed, sir.
Yeah, I think so. I think.
Surya, you know the case or Bhuvaneshwari? Because we have hardly like 10 minutes more to go.
Yeah, basically we want to just see the X-ray and ECG and make some comments.
If we could
counts.
It's okay, otherwise we tell the findings and then we can discuss.
But I think, madam, the problem is that I think their connection is lost. That is because all the three are in the same room. That is the point. They cannot hear
all
me.
Three are together. All
exactly.
three are together.
That is the problem.
Is all three are together.
Anyway,
in the hospitals,
while they come back, because there may be other postgraduates also.
Come back.
Yeah,
whenever you are the same room.
So if you could complete the case.
No, madam. The problem now, problem, madam, is that they must be in the same room. They are in the same room.
Exactly.
So there is a disconnection.
We together in one room and the other one is in other room. With the background, I think it's like that.
Yes,
anyway, what I will do is,
they came together, madam, and there is
no issue, sir.
Problem
no
the hospital.
Dr. Bala, Dr. Bala, what I will do is, there may be other postgraduates listening also. So we will we will have something.
Findings.
For example, for example, suppose in this particular child, if you take an X-ray, what you will expect would be one cardiomegaly, because the physical findings tells you a big heart. Second, you will expect is an LV apex. Usually the LV apex is down and out, whereas the RV apex is upturned apex. So you would expect cardiomegaly, you should expect a LV apex, and you will also expect an LA enlargement, left atrial enlargement, because it is a most likely a large VSD, post-tricuspid shunt. And you can even expect a right atrial enlargement. So there may be LV apex, cardiomegaly, left atrium, and probably plus minus right atrium. And you will naturally expect a pulmonary artery which is dilated and pulmonary plethora, right? So that is what we expect. Suppose in this, I have not seen the X-ray. Suppose this X-ray shows a less of cardiomegaly, that is lesser than what we expected. That would be not a good thing. Why? Because it will tell you that the patient may be developing pulmonary hypertension. So whenever you have a symptomatic VSD with a big heart, you are very happy because the child is operable. If you are having a symptomatic child with minimal or no cardiomegaly, you are very unhappy because the child is already developing pulmonary vascular occlusive disease like an Eisenmenger. Because you must remember, postgraduates should remember that even though the presentation of Eisenmenger is late in the second decade or third decade, the beginning of Eisenmenger is in the second year or third year. So you should not allow a large VSD or a large ductus to go into Eisenmenger. So that is why we practically close all those large lesions before 2 years at least. That is what we expect. Then the ECG, what you expect in this patient based on the physical findings of Sharon is that you will expect a biventricular hypertrophy. So what you will get is a relatively tall R wave in V1, tall R waves in V6 also, and mid-precordial leads have a high voltages. Both R and S are very prominent, and we give a very interesting name. I think most of the postgraduates will know that it's called a German word. It's a Katz-Wachtel phenomenon. So that is biventricular hypertrophy. Now, in this particular patient, or any other patient with a symptomatic VSD, if there is only RVH, again you are unhappy. Why? The patient is developing PAH. Suppose you have only LV, you will be very comfortable because there is a significant LV volume overload, and LA enlargement also will be there. So this is how you should look at the X-ray and ECG. So sometimes there may be a discrepancy between your physical findings and the X-ray and ECG. Then you should be a little careful. For example, here I expect a CT ratio of around 65%, and you don't get you get only 55%. You are not very comfortable because the patient may be going into a problem, right? And if you get only RVH, no LVH, it's a very dangerous thing. Maybe even child has a pulmonary stenosis, then that's a different. So this is how you interpret an X-ray and an ECG. Then naturally we should go and look at the counts and all for infection, etc., etc. Older child, of course, ESR may be useful to rule out an infective endocarditis. Hemoglobin is very important, basically one of the most important precipitating factor for heart failure at this particular age will be a low hemoglobin. But the picture of that boy seemed to be okay, no? The child was looking reasonably bright and all. Sharon, Surya, can you hear me now?
Yes, sir, now.
Yeah, quickly show X-ray and ECG, quickly. Because even postgraduates will be feeling little dull and non-responsive now. 2 hours. Just
have that X-ray, have that X-ray with you. Star is asking for the X-ray. Sir is asking the X-ray.
Yeah, they are coming with the yeah. Bala sir, see, look at this. Almost every book is there. with them. Oxford Handbook of Pediatrics, from OP Guide to Perloff, super. Piyush Gupta's textbook. Nelson is there. Okay.
They're keeping everything in there.
That's good. That's good. At least myself is in the dinosaur in the.
Sir, can you see the screen now?
Electron. No, I can see. We can see the screen, but not the X-ray. I can see all these.
We have shared the screen. Sir. X-ray is now audible.
You are audible, but your desktop is seen. But with all those practical peds, poisoning.
The cursor is in park cardiology.
Okay, you can discuss, I think.
Okay, I think, yeah, I think now I will ask you, can you hear me, Surya?
Sir, it's audible for me, sir, but not able to share the screen.
No problem.
Okay, doesn't matter. Surya, Surya, what will you do? What will you do? What will be the
discuss?
Yeah.
Okay,
so
sir.
what will be your management in the hospital and outside the hospital, and then later in the hospital? Basically, what will you do in principles only?
Sir, it's medical management, sir.
Yeah, yeah. You have an X-ray coming in. Very good.
So now it's audible. Now it's visible,
Yes,
sir.
yes.
Yes, I just seen. Correct. Yeah, Surya, you ask Bhuvaneshwari to read the X-ray. Bhuvaneshwari, quickly. Yeah. 1, 2, 3. Cardiomegaly, yes or no?
Yes, sir. Cardiomegaly.
Okay. Is it more like an LV apex or an RV apex?
It's like LV apex, sir. It's
No,
down and tagging, sir.
No, I think it is more like a RV apex. It is upturned apex. So that is a point. Then you have the right atrium is very prominent, right? Based on this X-ray. And the left atrium also is enlarged. It's a straightening of the heart border. So there is significant cardiomegaly, which is reassuring, but there is an RV apex probably indicating a significant pulmonary hypertension and biatrial enlargement, which we expect in a large VSD and increased vascularity. I think there is no danger of this becoming a pulmonary vascular occlusive disease. Is it an AP view or a PA view, Sharon?
AP view.
This is an AP view because spines are very prominent, right? Ribs are more horizontal. Can you go to the ECG?
Actually, it's above the level.
Okay. Now, ECG for 2 minutes, 2 more minutes. Yeah. ECG, you should look at the P wave in lead 2, which does not show any left atrial enlargement. And also there is not much of right atrial enlargement. The reason is that the sensitivity of ECG for right atrial enlargement or left atrial enlargement is only 50%. So if you have 100 left atrial enlargement, only 50 ECGs will show a left atrial enlargement. So that is the point. And you should look at the PR interval because the child may be on digoxin, and the earliest physical finding of a digitoxicity is a prolonged PR interval. And if you are suspecting an atrioventricular septal defect presenting like a large VSD, you would expect a prolonged PR interval. Then QRS axis is very, very important. And here lead 1 is positive. Where is AVF? AVF is negative, right? AVF is negative. So that is a very, very important point. What does it mean? It is the left axis deviation. It's the left axis deviation. Sharon, in this patient presenting as VSD, if you have a left axis deviation, what are you thinking of? Very interesting finding, right? Sharon?
Sir, left ventricular hypertrophy.
No. That is not the point. You are diagnosing clinically a large VSD with significant pulmonary hypertension. Unexpectedly, even I was surprised to find that there is a left axis deviation. As a pediatrician learning cardiology, what will you think of? Any 3 of you can answer. You should expect it to be an atrioventricular septal defect. Whenever you find a clinical finding of VSD with left axis, you should think of a AV septal defect. That is one. Then the VSD, there is something called inlet VSD. You said about outlet VSD. A large inlet VSD will have a left axis deviation. And the third is not very common, is multiple muscular VSD. What you call as a Swiss defect will have a left axis. So here I would say it is a choice between a large inlet VSD or a atrioventricular septal defect. And as you can see in the precordial leads, both RRS are more or less equal to each other. So it is a biventricular force. So overall, I would say that it's a left axis deviation is a real eye opener, which means you should, when the cardiologist does an echo, the cardiologist should be aware of this ECG. Then we should be looking for either AVSD, which is very easy to diagnose, and you should also be looking for a large inlet VSD. So that is what I would say about the ECG. So here ECG is, I think, a very crucial pre-echocardiography finding, which will direct the cardiologist to look for this particular situation. Okay, I think with everybody's permission, we shall we conclude, or because 2 hours. Hello.
Sir, if you want, you can take a 10 more minutes.
The echo. Sir,
yeah, large.
Once again, can you repeat?
Okay, so there is a large inlet VSD. See, I think that is the plan.
The echo showed large inlet VSD, 12 millimeter in size.
Okay, so Sharon, you understand. So I think one of the most important 2 points in this X-ray and ECG, very important learning lesson for the entire lifetime of pediatrician is that if you have a RV apex instead of an LV apex, you think significant pulmonary hypertension. But we are very happy to see cardiomegaly. We are very happy to see LA enlargement because it is an operable condition. And unexpectedly, we had this, we expected a right axis deviation and you got a left axis deviation. You should think of an AV septal defect or an inlet VSD. And you should know that inlet VSD can never ever close spontaneously. And this child is rightly pointed out, it is the right time to operate on this patient. So this child, even after surgery, because it becomes late operation, again can produce a post-operative pulmonary hypertension. We have seen many children having a post-operative severe PAH behaving like an Eisenmenger syndrome. The child is on follow-up, right? Good. Child had undergone a VSD closure and 2 months post.
December. So it's last month, 2 months back.
Okay, very good. I think it's a lovely story in the sense that many times what we find is that at the end of the case presentation, we find that the child is inoperable due to a complex congenital heart disease. Here, everybody goes well. No, when we go up, we go to sleep, we feel very happy that child had a corrective surgery, and in spite of some of our internet problem, I think we had a reasonable interaction, I suppose. Yes, Sharon.
Yes,
yeah. So
this is the picture of the child when he came for follow-up. Sir, actually, he's doing well with weight gain and
child is slowly becoming. Yeah, child seems to be a little becoming obese. Anyway, child's nutrition is very good. I think that's great. I think this is the important point because okay. So I think I will give the mic back to our organizers.
Thank you, sir. Can you stop slide sharing, please?
Yeah.
Yeah, thank you, sir, for your excellent interaction. And I request today's judges, Dr. Rama Chandramohan, madam, is there. Please, madam.
Sir, good evening, Dr. Sulfikar, sir.
Good evening, ma'am. Hi.
Such an excellent session, sir. We learned so much from the session. Whether the postgraduates benefited or not, I think we all benefited a lot. You were so patient with them, and each line you explained the reason for it, and very, very impressive class. I mean, I know for your level, I don't know where to say all these things, but it was really, thank you so much for that excellent session.
Thank you. And I think you are very kind anyway.
Really good. So what
Dr. Srinivasan, sir. Yeah.
Srinivasan, sir.
So unmute, sir. Unmute.
Yes. he will say only good things about everything.
Sir, Dr. Unmute, sir.
Hello.
Sir, Kekam.
Yeah. So it is a wonderful discussion, and the candidate was doing very well. Probably because of the connection, she became a bit
correct.
upset. Okay. Anyhow, in spite of all this thing, hurdles, the discussions covered every aspect of congenital heart disease, right from the etiology and also how you have to go about. So thank you so much. It was learning experience for me also. Thank you.
Thank you, sir. Dr. Ramesh, sir.
Sir, I have a few comments, sir. In spite of the technology failure, the chairperson did a wonderful job. As I requested in the previous session, you can ask the 3% to sit separately into separate Wi-Fi and mobile data connection, and let everybody have the papers with them about the findings and other things, so that somebody can overtake. And about this child was presented with recurrent respiratory infections and difficulty in breathing. As chairperson pointed out, you have to first define whether it is respiratory or cardiac in the beginning itself. Even if you know the diagnosis at the end of the presentation, you should not modify your findings in the history. Because if respiratory infection, it will be...
I was about to say, I was not about to tell when Rama was commenting.
Climax interesting. Second thing, you have to quantify the recurrent respiratory infections. Because earlier, 3 decades ago, 3 to 5 respiratory infection, the age group of 6 months to 6 years, quite common. Now with this schooling, early schooling and pollution, even up to 6 to 8 respiratory infections are common. And you have to qualify also, because less than 6 months, they will have simple running nose, sneezing. The mothers, anxious mothers will call them as sully, and they should not equate it with the respiratory infection. It may be a physiological phenomenon. And you must also quantify whether they had how many hospital admissions, how many hospital visits, whether it is a significant respiratory, because every alternate child comes to a doctor every 1 or 2 months. And about the head to foot examination, Dr. Balasubramanian was saying, as pediatrician, we always do a head to foot examination in the general as a part of general physical examination, because some parts of the body like high arch palate, ear abnormality can give a chest abnormalities, can give a clue to the heart disease. And fourthly, it is about the growth and development. Growth and development will come after the head to foot, then anthropometry, and then vital signs. Then only go for the systemic examination. And growth, it has to be expressed both in the history, not only development, also the growth, whether the child was growing initially well, and especially when it was breastfed and then started falling in the percentiles. And it is better you express in terms of percentiles. Other than that, it is a wonderful discussion. As Dr. Rama pointed out, we also learned many things. Thanks, presenters. But they put up a brave face in spite of all that. I congratulate them really. And thank you, sir, organizers, for the opportunity.
Yeah, thank you, sir. Yeah.
So can I offer some comments?
Yeah, please, sir.
Yeah, I think. Yeah, most importantly, I think I must congratulate all the 3 postgraduates. Sharon, particularly, I was very impressed with her quick responses. Especially, I'm very happy about this Kupaswamy business. Anyway, it's nice because practically nobody knows about the Kupaswamy and all. And Surya already, Balasa was saying, no, he is you should have it should be like a combination of 50% MGR and 50% Shivaji. So it should be collected, but very active, vigorous and all. So you should try to reduce the speed. Bhuvaneshwari is also, I think she has also this thing. And one of you can, you can get my cell phone number from your boss and send me on either of one of your emails. So I will probably send some what you call as the study material, PowerPoint presentation. So what a word material I will.
Thank you, sir. I got your number, sir. I'll give it
so
to
you
them.
just give them the number, and one person can. I will send within 1 or 2 days. I will. And Sharon, if I forget, within if you don't get my PowerPoints by Sunday evening, you call me again. No problem. Absolutely no. Because I
will remind you, sir.
Hello.
I will remind you.
Yeah. Okay, sir. Okay, sir. Okay, sir. Thank you. Thank you, sir.
Sir, if you want, we can put in our WhatsApp group also. Everybody will get benefited.
Okay. Right, sir. Thank you. We'll do that.
Yeah.
We'll do that.
Yeah.
So Sharon is got a responsibility for that. So she can remind me if necessary.
So I can coordinate, sir. I can coordinate.
So all three of you, best of luck. And how many students are there present appearing exam for MD?
17 students.
Oh my God,
17.
it's a huge number, almost 17 students. But okay, that's good. So Madurai. So I've been so somehow for a long period, from almost in the 90s, mid 90s, from Dr. Edwin's days, we are so linked, Trivandrum and Madurai, myself and Madurai Medical College. So now our PGs will remember, oh my God, he's an ancient person. He knows Dr. Edwin, so he must be pretty old. Anyway, Sharon and Bhuneshwari and this thing, everybody. Thank you, and thank you, everybody. Oh, thank you. Good night.
Thank you, sir. Dr. Bhuma, madam. Yeah, very please.
Bhuma, yeah, please.
Thank you very much, sir. Zulfikar sir, we also learned so many things. Like more than a faculty, we felt like a student, because every point you discuss, and as Dr. Ramesh has also told, like the presentation was very excellent, even in spite of so much of the technical glitches they were able to do it. That shows the confidence in them in presentation, and I wish you all the best in the forthcoming examination. And thank you, sir. And one more point, again, I want to emphasize, during the present illness, don't give a clue. Don't give a clue like what is the case, and don't say like they're treated by a private practitioner, found to be a diagnosis, and those things like usually it's okay, but always keep the examiner what is going to be the turn. Then only it is more interesting, and more questions which the answers will be asked. Don't give the answers first itself.
Thank you, madam.
Sometimes you must tempt the examiner to ask questions. Sometimes you must tempt the examiner to ask questions.
Correct.
Yes, exactly. And that the questions should, in which you know the answer.
Yeah, naturally. But ma'am, the problem is we have all gone through our examination. So when you go back and find it's a very stressful situation. The theory is very easy. Theory is very easy. You have to fight only yourself. But practical, it's a very tough thing. But still, I think they're doing well.
Practically, for the past 2 years, everybody is with COVID orientation only rather than pediatric.
Orientation.
Yes, sir.
Okay, ma'am.
Thank you, sir. Thank you, sir.
Dr. Balasubramanian, sir. Yeah.
Thank you, sir.
Good night, all of you.
Yeah. On behalf of IAPTNS, I thank Dr.
Rajendra Nange.
Hello?
Hello?
Yes, sir.
Yeah, we can hear
Yeah, on behalf of IAPTNS, I thank Dr. Zulfikar sir and Dr. Balasubramaniam, Dr. Bhuma madam, and today's judges, Dr. Ramachandra Mohan, Dr. Ramesh sir, and Dr. Srinivasan sir, and all the presenters today presented very nicely. I thank one and all for this wonderful opportunity to come to IAPTNS. I thank all the delegates as well as faculties who has attended today's event. Thank you very much. Thank you, sir.
Thank you, sir.
Good night to all.
Good night, sir.
Yes, sir. Thank you.
Good night, sir. Good night.
Good night.